lecture. So I'm going to talk a little bit about the bispecific antibodies, and I don't think that this is an one or the other approach. I think these are therapies that are clearly advancing outcomes for our patients, and I think it's just good news. And they'll both find a place in the treatment landscape. And again, I think that's just good news for patients. So I'm going to cover what is a bispecific antibody. You already heard a very nice introduction as to what this is. We'll talk about what clinical scenarios where we currently have FDA-approved products, and also I'll walk you through the trials. It's going to get a little bit deep in the weeds, but I think sometimes that's helpful so patients understand how we approach this. It's really based off of how the trials were conducted. That then leads to FDA approval, but also share some insight as to where we're headed in the future. So first off, you kind of heard this already. What are immune therapies? So you heard a very nice overview of how we harness T cells by removing them from patients, using a virus to modify them so that they can then target CD19 on the surface of B cells. They have this additional primer so they get activated when they engage their target. We're going to apply those similar principles when we talk about bispecifics, with the major exception that we don't have to remove T cells from the body. We just apply these antibodies, just like rituximab you heard. They have a second head that's going to engage those endogenous T cells that are just circulating by, harness them, bring them into that microenvironment so that they can then engage that tumor. It's going to lead to supraphysiologic engagement, so that does then translate into some of the side effects, which you've already heard about, those severe flu-like syndromes. You're going to see similar toxicities with these bispecifics because they're also engaging T cells much more aggressively than what would otherwise normally happen. And again, the bispecifics essentially has two heads, one that targets the tumor protein. You have a little bit more flexibility here because you could potentially program it to target any antigen or protein on the surface of a tumor cell. And then the other head's going to engage the CD3, which is on the surface of those T cells. So in terms of engineering, there may be more flexibility in this technology that, again, with programming, you could then have more broader application. There are several that are currently FDA approved, which I'll walk you through, and others that are being considered. So there might be a fourth one approved later this year: mosunetuzumab, epcoritamab, glofitamab, and odronextamab. They do vary somewhat in terms of their structure, which we've outlined here. So the one to point out is glofitamab has a 2-to-1 configuration. That means you're going to bind two surface markers on the lymphoma cell versus one that's going to bind the T cell. So that may then translate into better potency. Epcoritamab has a region at the bottom that can actually still be active. So as you saw Jeremy highlight the NK cells, so this could actually also engage NK cells, not just T cells. So that's one unique feature of epcoritamab, in addition to the way it's administered, where it's a subcutaneous route. That means under the skin as opposed to intravenous. And then odronextamab actually started earlier, but is a little bit later in terms of getting to the clinic. And some of that is just drug development and how the trials were conducted. But it did shed some light on how we can give these therapies a little bit more safer in terms of the step up that happens in the first month of treatment. I mentioned the side effects at the beginning of this because there is no free lunch. There's always going to be some toxicity that emerges when you're engaging T cells. In my experience, this is a little bit less than what we see with CAR T, so it does open the door for potentially more patients and more centers specifically that could potentially deliver this. But it's still probably underutilized. So despite having 3 that are currently FDA approved, the number of patients that have actually been treated with a standard of care product is still a lot lower than I would like to see. And so this does highlight that there's still a learning curve and there's infrastructure that needs to be built because this can cause some unpredictable flu-like syndrome. And as you heard with Dr. Abramson, with CAR T, we've gotten really good at delivering that, but it's still in a more controlled environment. Generally, a lot of those patients are either in the hospital when that flu-like syndrome can occur, or they're really closely nearby, tethered essentially to that infusion center. This could potentially be vastly different, where this could potentially be given in your traditional community practice. What happens when patients have these flu-like syndromes that happen after hours, so in the middle of the night. So it creates some, again, opportunity for learning, but need for infrastructure to handle these unique toxicities. So I'm going to start with mosunetuzumab because it was the first that was FDA approved. Again, it targets CD20 on the lymphoma cell and CD3, which is the endogenous T cells. It's essentially rituximab. It's the same maker of rituximab. It just has a second head. It was studied in relapsed refractory follicular lymphoma, so patients had to have had 2 prior lines of therapy. And I'll draw your attention to this step up. We learned early on that if you just administer this every 3 weeks, you're going to have uncontrolled fever and flu-like syndrome. So if you give it a little bit more controlled, so a very low dose at day 1, it's a little bit higher dose at day 8, and then you get to full dose by day 15. So that's an inconvenience for patients that we fully acknowledge. You have to come in once a week for 3 weeks, but it's a little bit more controlled engagement of those T cells. So though you still see flu-like syndrome, it's not quite as dramatic as if you just slug people with a dose every 3 weeks. But what is unique about these newer antibodies is they do have a longer half-life than blinatumomab, for instance, which was a BiTE that was approved in ALL several years ago, where it has to be continuously infused because it just doesn't stick around in circulation for very long. These now allow us to give it every 3 weeks. So once you get past that dose step up, there is a convenience factor where you then give it every 3 weeks. And the other thing that's pertinent about this, if patients were in a complete response after 8 cycles, they stopped. Now, if they were in stable disease or partial response, they could continue up to 17 cycles. So that means you could stop after about 6 months of therapy if you had a deep response, or you could go out to a year of therapy, but there still is an endpoint. So though it's not a one and done like CAR T, there is a fixed duration of treatment here, which, again, sometimes we make assumptions for patients, but my assumption is that you would like to get on with your life and not continue to spend a lot of time with us. And so there is some advantages to having treatment that has an end date in sight. And based off of depth of response, it could be sooner than later. Now, these are the baseline characteristics. So again, this is how we consider who should be considered for this treatment. We look at what did the patients look like on the studies that received this treatment so we can then reproduce those findings. And you can see large proportion of patients refractory to their prior treatment, over-enriched for patients that were progressing quickly after chemoimmunotherapy, which we define within 24 months of chemoimmunotherapy, and also refractory to prior CD20 antibody, which that's important to recognize because, again, many patients with follicular lymphoma are going to cycle through multiple therapies. Oftentimes they get retreated with CD20 antibodies like rituximab or obinutuzumab, so we need to really understand how does this therapy that's also targeting CD20 going to behave in that patient population. Again, cytokine release syndrome was the most common side effect we see here. So that sort of tornado plot, the top is the most frequent, followed by less frequent side effects. Cytokine release syndrome, which is fever, flu-like symptoms, fatigue, myalgias. Sometimes blood pressure will drop, oxygen levels will drop if it's more severe. Fortunately, in these situations, most of the time it was fever alone, so they didn't have to be hospitalized to be monitored, which I think is a big step forward in terms of access. But following cytokine release syndrome, you see fatigue, you see headache, you see low blood counts. So again, side effects that we would expect when you're engaging the immune system. Also sort of a proof of concept, which is reassuring to us that it's actually doing what we hoped it would do. It's not just putting a flag on the surface of the lymphoma cell and hoping that you'll have passive immunity like you heard about. This really is harnessing those T cells more dramatically than you would expect in a passive response. The other thing we've learned is that most of this happens at the beginning, so the first cycle. You're going to see more fever happening with that first infusion, a little bit less with the second infusion, and then probably the greatest risk is going to be with that third infusion where you get to high dose. Predictability is key because we're sending patients home. This fever is not happening when you're in the infusion center, so that's different from an infusion reaction, which we're very skilled at nowadays, where patients start their infusion, usually an hour in, they start to have the chills. Fever is not as common. This is fever first, and it's usually happening about 5 to 6 hours after that first infusion when you're home. So again, key element to this is we have to prepare people for that. They need to know what to do when they have fever. So contact information is critical because we don't want you out there by yourself dealing with this and not being able to get in touch with anyone. So again, that infrastructure becomes important. Methods of communication become very important. This is the early days. We'll get better at this, but as of right now, we share our cell phone contact information with patients because we really want them to feel comfortable that they can get in touch with us when this happens in the middle of the night. If they just have fever and they don't have lightheadedness or shortness of breath, and some centers are more skilled at this than we are at Anderson currently, some will send you out with a thermometer, a blood pressure cuff, an oxygen saturation monitoring device. That's ideal. In a low resource situation, really you just need to know, are you lightheaded, are you short of breath? If you have none of those and it's just fever, you could take a dose of Tylenol and repeat your temperature an hour later, because you can see here most of these were grade 1. That means it was fever and isolation. The grade 2 is whenever the blood pressure drops or the oxygen level drops, and that's usually patients that need to get to an emergency room or an inpatient setting because we're going to approach that with IV fluids, slap some oxygen on. Fortunately, it's really rare to see grade 3 or higher side effects. So that's whenever the blood pressure is so low that it's not responding to IV fluids, potentially may need to be in the ICU where we give medications to raise that blood pressure, and it's more than just a nasal cannula. Sometimes it's a mask to deliver higher rates of oxygen. That is possible, and that's why it's critical for us to understand these side effects, be able to tell patients when to come in, because that's worst case scenario in our minds. Best case scenario, you take a dose of Tylenol and you're through the storm. The other aspect that we'll get much better about, and LRF is playing a key role in this, is providing guidelines for, in addition to calling your doctor when you have fever, when should you start something like corticosteroids, dexamethasone or prednisone, to try and mitigate some of these symptoms from getting worse. Again, it's early days, and I anticipate we'll get much better at this. Right now, with my first call with fever, if it's after the first infusion, I'm going to say take a dose of Tylenol, check your temperature an hour later, and call me back. If it's after that day 15, where it's full dose, where I might be anticipate a little bit higher rates of toxicity, take that first dose of Tylenol. If you're still having fever an hour later, initiate that steroid dose. So again, we're going to get better over time, but this just highlights that about 10 to 15% of patients needed steroids in addition to something called tocilizumab, which blocks those cytokines, because once T cells get activated, they want to bring more to the party. They release cytokines, they bring other friends in, NK cells, T cells. Those cytokines make your blood vessels leaky because you got to get blood cells trafficked into those lymph nodes or tumor sites. When the vessels get really leaky, that's when the blood pressure drops, that's when the oxygen levels start to drop. And so sometimes just blocking those cytokines with a drug called tocilizumab can kind of slow it down. But fortunately, again, if you think about this versus CAR T, much lower use of steroids, tocilizumab. So again, potentially broader access to this because you'll be able to do it in centers where they may not have access to those things or training. The other thing that's really critical, we want to know who's going to have grade 2 or higher CRS as much as you want to know, because that's going to reduce my anxiety when I get that first phone call and know, should I just send you straight to the emergency room or should we stay at home and try a dose of Tylenol and see what happens? And so again, it's a relatively small number of patients that have been treated on this trial, but what we did learn from this study is that if you had bone marrow involvement with your follicular lymphoma, or if you had lymphoma cells in your blood that could be picked up by a CBC, higher rates of grade 2 or higher CRS. So again, we're learning as we use these tools, but that might prompt me. If I have someone who I know has bone marrow involvement, with that first call, I might say, all right, let's just go into the emergency room and see how this plays out over the next few hours. So that was really important to learn that. The other key takeaway message, if you get a complete response with this therapy, there's a very good chance you're going to stay in a complete response. And just like Jeremy shared stories with his first CAR T experience, my first bispecific experience was a 90-year-old gentleman, fantastic social support, tons of disease, progressed through several therapies, had a very large bulky mass in the pelvis. He definitely had fever with his first dose. Had more fever when we got to day 15, actually ended up hospitalized briefly, got through it. First response was a complete response. He's been in remission now about 3 years, to the point where I said, we don't even need to worry about lymphoma anymore. Go on, live your life, do well. So again, that just highlights the type of patient who potentially is going to benefit from this therapy. And if you get into a complete response, there's potential that this could be curative. We don't have the 5-year follow-up yet with CAR T to feel confident in those statements, but we can see from these types of Kaplan-Meier curves that there's clearly patients in that tail end of that curve that are staying in remission, and it's more likely to be true if you have a complete response. So depth of response, I think, definitely matters. And again, this is the patients who achieve a complete response tend to stay in complete response with about 6 months of therapy. And overall survival looks really good, which I think is an important measure. We want patients not only to be in remission from their lymphoma, but we want them to live a long time. I'm sure that's what you want as well. And so again, very high rates of survival with these bispecific therapies. So that tells me we're not inducing toxicity that's life-threatening like we sometimes do with chemo or radiation. Glofitamab is approved for diffuse large B-cell lymphoma. That's that 2-to-1 configuration, so targeting 2 CD20s to 1 CD3. It's a little bit different in terms of how we administer it because it's potentially more potent, and we did see in the phase 1 study more cytokine release syndrome. Obinutuzumab is given a week ahead of time. So that's kind of like rituximab. It's a naked CD20 antibody with the goal of binding up any B cells that are out in circulation, so that when you introduce glofitamab, though you're still going to likely see cytokine release syndrome, it may be a little bit less severe. And so that's one unique aspect. in my opinion, higher complete response rates, particularly with aggressive lymphoma with glofitamab. So again, you're trading off a little bit more toxicity with the benefit of a potentially a little bit more efficacy. And what we also learned from the study is that the patients who achieve a complete response tended to do very well. And this was in aggressive lymphoma patients that otherwise were facing very poor outcomes, including several of which that had had prior CAR T-cell therapy. I think the next question is, what happens at the end of treatment? Are we comfortable stopping therapy? That's a big question that we're all asking with bispecific antibodies, because I'm going to show you epcoritamab where they dose until progression or intolerance. Glofitamab also has a fixed duration of treatment. It's a little bit different than mosunetuzumab, but after about a year of treatment, you do actually stop glofitamab, which makes us a little nervous, as I might imagine makes patients nervous, because if this is working, why would you stop a treatment that's working well? And so this was an analysis looking at the end of treatment, what actually happens to patients when we pull back the drug. And so the good news is the majority of patients who achieve a complete response stay in a complete response, even when we peel back the drug, hinting at the likelihood that we're curing these patients by harnessing their T cells to get rid of the lymphoma cells. So it's early days, small number of patients, but this is really promising, and that's why we're so excited about these new immune therapies, because T cells can clearly achieve things that we've not ever been able to achieve very successfully with chemotherapy, particularly in the relapse setting. What about epcoritamab? So I mentioned it's unique in that we administer it under the skin. It's a subcutaneous administration, but it also has the bottom of the antibody that's still active, so you could potentially harness NK cells in addition to T cells. So that's the unique aspects of epcoritamab. It's currently FDA approved like glofitamab for diffuse large B-cell lymphoma, also in that third line or later setting. So these are patients that had at least 2 prior treatments and the lymphoma still came back. And again, about 40% of patients on both of these studies had had prior CAR T-cell therapy. It's a busy slide, but the Kaplan-Meier curve, so the percentage of patients alive and without recurrence is down on the bottom corner. Again, patients who achieve a complete response tend to stay in a complete response. Now, this one is dosed until progression or side effects that suggest we should peel back. Fortunately, after the first month, most of the side effects are generally quite mild, with the exception of infection. So just like CAR T, where we're suppressing B cells for an extended period of time, and normal B cells are generally needed to mount an antibody or immune response, so viral infections are particularly challenging in my experience, particularly as patients stay on these treatments longer and longer. We just keep suppressing B cells for an extended period of time. So because of that, we're now asking the question, do you really need to continue this until progression or intolerance? I will say in the US, we're more interested in asking that question. In Europe, where they have fewer options, it's less of an important question because, again, the argument, if it's working, why would you peel this back? And so side effects is probably going to be the one rationale, and particularly as it pertains to viral infections. But again, it's early days. We potentially will have this question asked and answered in the next few years. One of the interesting aspects of epcoritamab is in Richter's transformation, which has been a disease that's been particularly challenging to handle. So that's patients who have underlying CLL. It transforms into a more aggressive lymphoma, diffuse large B-cell lymphoma. And what's unique about Richter's versus other aggressive lymphomas is that the immune system is much less active. Just by and large, you have CLL and it's transformed to Richter's. And so there are questions, can immune therapy that's harnessing T cells, particularly without having to remove them from the body and modify them in ways that Dr. Abramson just described very eloquently. We're just using your T cells that exist, that have probably been exposed to prior therapies that may impact their ability to react. And so it's a small study that's been done with epcoritamab in Richter's transformation, but again, looks very promising. So that's a waterfall plot. So the x-axis is where you start on therapy, and anything that's below the x-axis means that's a reduction in tumor volume over time. And then this other swimmer's plot kind of shows where patients are along the journey. And so, again, small number of patients, the majority of them responded to this treatment, and many of them are still in remission, which, again, is really encouraging, particularly for a situation, though rare, can be very difficult to manage. And I'm going to end with odronextamab. It's not currently FDA approved, but we're anticipating that might be the case in the next 6 months to 12 months. So odronextamab was studied across a number of B-cell malignancies. So just like we've got CAR T across all these tumors that express CD19, you should envision that these therapies should work well across any CD20 expressing lymphoma because you're just targeting a protein on the surface of the cells. I alluded to the fact that there are nuances, such as Richter's, where the T cells may not be primed for such a response. But you can see here in this study, they had several different cohorts, large cell, follicular, mantle cell, and other B-cell lymphomas. And when we look at what we learned from odronextamab, they got put on pause for about a year to sort out how can you safely give this without causing too much in the way of cytokine release syndrome. And so they really slowed down that first month. So they split the dose over 2 days. Instead of just once a week for 3 weeks, you get 2 consecutive days, once a week for 3 weeks. And they were really conservative in terms of that dosing. And by doing this, the rates of cytokine release syndrome dropped dramatically. So again, we appreciate patients being willing to participate on studies because it helps us understand this, but it really shed light that you just have to go slow in the first month. That will reduce the risk of fever and flu-like syndrome that can be more severe if you're too aggressive. And with this, again, very highly refractory patients included on this study, including CAR-T, but also prior auto study, transplant progression events. Very high response rate with odronextamab. Now, it's hard to compare across these studies because, again, we get a little bit better at choosing patients, get a little bit better at slowing down some of the toxicities. So, again, this one's a little bit slower in development. So I don't know that I would conclude that, oh, this response rate's higher, this must be the best bispecific antibody. It's clearly encouraging. We see very high response rates, very high complete response rates. Again, it appears to be quite durable in very refractory patient population. So I anticipate this one will be approved. And as I mentioned, once they adjusted how we deliver it in the first month, we've gotten much better at reducing the severe cytokine release syndrome. And so where do we go next? You will likely see at least 4 bispecifics that are FDA approved. How do you navigate that? We have several CAR T-cell therapies that are FDA approved. So you'll probably have some investigator biases. How much experience do they have? Did they participate on the study? What are the patient-specific characteristics? How closely did they mirror the trials that led to the approval? How worried are we about cytokine release syndrome? In my experience, mosunetuzumab is the easiest to deliver, very low rates of grade 2 or higher cytokine release syndrome. Glofitamab is a little bit higher, so that's likely why we have glofitamab approved for aggressive lymphoma, mosunetuzumab approved for follicular lymphoma. So again, there are a lot of nuances with this, but I do think that bispecifics are clearly an exciting class of drugs. I'm very excited to have several of them approved. I don't worry about CAR-T versus bispecifics. What I anticipate will happen, the bispecifics will move into first-line therapy in combination with some of our standard treatments because that's where most of the trials are happening right now. Or maybe second line in follicular lymphoma. You'll have CAR-T that really has a role in second line large cell lymphoma, and I think every patient who relapses with large cell lymphoma, CAR-T should be considered first. And then you'll still have the potential for bispecifics to sort of rescue those patients where the CAR-T didn't give us what we wanted to achieve with that. So again, I'm really excited about bispecifics. I'm excited about CAR-T. I'm excited for patients. I'm appreciative for patients that are willing to participate on these studies so we get this therapy approved for more. And absolutely appreciative for the LRF to be able to share this information, to get the message out, and to partner patients with people who've gone through these therapies that can shed light on the things that we never even think to counsel about. So with that, I'll conclude. I'm happy to answer any questions.